What's up? Whoop, whoop. Let's go, trees.
Good morning, folks on Zoom. Alrighty, I'm gonna go ahead and screen share here. I think I have videos, but just in case, I'll share the sound. Alrighty, so today we're starting our last chapter for the semester, which is on health psych. I haven't yet, but over Thanksgiving break, I may add in some slides about COVID, just because we're finding a lot of really interesting psychological things related to it. I mean, not me personally, but the field. So I'm gonna turn this so y'all can actually see me on Zoom and take attendance real quick, and then we will dive in and get started. Go ahead and do the slideshow so that what I'm saying shows up as captions. There we go. All right. We get birds. No, you'll get it. So the next exam is all 4 chapters. So you'll get it next week. And then it won't be due until the day of our presentations. Okay. So you'll have a whole week to work on it. I had a moment of panic, like, am I supposed to give you an exam? No, I'm not. We're good. Okay, I'm just gonna pull up the participants list. So I can give everybody on there some credit here. See who I need to check in with. Awesome. Okay, so health psychology, like, is and isn't a new field. That sounds weird, but I mean, medical doctors have always been the ones who are sort of first line to treat psychological illness, right? Because if you have something going wrong, you typically go to your primary care doctor as your first check-in. And then psychologists have always been interested in sort of this mind-body connection. That being said, the idea of health psych as like its own specialized field is fairly new. I would say maybe since the 1980s, 1990s, which I know is like ancient times for y'all, but I was alive, so it feels like not that long ago for me. And so what I've done here to just sort of shake stuff up from your chapter is while I was on my internship year, I actually worked a health psychology rotation. And so I am actually going to speak about the areas where I worked, where I have a little more knowledge than other areas. So we're going to start by talking about HIV/AIDS. And really interestingly, obviously, when I first made this lecture 12 years ago, I didn't think about this and how it would relate to the current pandemic. But there are a lot of similarities, unfortunately, in terms of marginalized peoples just being sort of forgotten about and be like, oh, they can get the disease, it's fine. And also people not listening to the science. So HIV stands for human immunodeficiency virus, and it's a type of virus called a retrovirus. So it's made up of RNA, and then that converts to DNA, and then that's incorporated into your cells. And somewhere on the order of 1.2 million people in the US are infected. And there are several phases when you first contract HIV. So for the first few weeks, the virus multiplies in the body and you'll get just like flu-like symptoms. So you might think, I just caught a bug, this is like a bad cold, right? And you might even get a rash, but even that, might be like, oh, did I like buy something new and not wash it? And then you kind of go into a phase where you don't have any symptoms. So again, a lot of people think, oh, I just had a little blip, a little bug. But then what happens is you have a gradual deterioration over time of the immune function. And some people feel pretty healthy during this time. And in fact, this gradual decline can last up to 10 years before someone gets diagnosed. But the whole time the virus is damaging your immune system. And so how do you tell if someone is infected? Well, obviously there are HIV tests you can take, but once someone comes in and we're pretty sure they have it, there are a couple things we can look at from blood tests. So one is the CD4 count. And this looks at your T helper cells, which are part of your immune system, a really important part of your immune system. And healthy folks have a range of 800 to 1500 CD4 cells in a milliliter of blood. So 800 to 1500. What happens in folks with HIV is that this will drop. Essentially, the virus kills these helper cells. And so once your count is less than 500 CD4 in a milliliter of blood, then half of the immune reserve that your body has been destroyed. At that point, when you get minor things, cold sores, warts, fungal infection, yeast infections, little colds, right? They all are much, much, much worse, much, much harder for your body to fight. And once your count drops below 200 CD4 cells in a milliliter of blood, then you're vulnerable to opportunistic cancers and infections that typify AIDS. And AIDS is adult immunodeficiency syndrome. And it's essentially the late stage version of HIV. And in fact, the CD4 count of less than 200 is diagnostic. When you have that, then essentially you're moved from HIV to AIDS. Viral load is something else we look at, which is basically the amount of the virus, the HIV virus in your blood. And it's, again, we like to do 1 milliliter of blood. And it's the copies of the HIV virus per 1 milliliter of blood. And treatment should be offered to anyone with over 100,000 copies per milliliter. And the best results you have once you're on medication for HIV is it'll come up in your blood tests as undetectable. That's great. That means it's being really well managed. However, what confuses some people is they think, oh, undetectable, that means I don't have it. Unfortunately, you can still transmit it to other people. And it can be influenced by co-infections. So again, if you have HIV and you get something like COVID, the flu, what have you, then that can affect your viral load. And this also can be used for diagnosis. So you can detect changes in viral loads as quickly as a few days after infection. And a standard HIV antibody test can take 2 to 6 months to register. The other thing that viral load is used for is to see if the treatment is working. So the treatment here, I have some slides about it, so I'm going to wait so I have that information up there. So this shows you those numbers. So on the left axis, the blue numbers, this is your CD4 count. On the right axis, those are your HIV copies, your viral load. So what you can see is here again, you get your primary infection. Your CD4 counts really dip, but then you have that sort of period where your body kind of adjusts to it, right? And it starts to get better, and then it just goes down over time. And then here is that viral load. This shoots up pretty quickly. This is usually when the people feel like they have flu, something like that, right? And then it kind of dips for a while. Again, it can be really hard to figure out. They call this clinical latency. And then it will go up at the end, again, if it's not controlled. And so this part they call acute HIV syndrome, when you get those flu-like symptoms. And then at the end, again, if it's not controlled, you'll get the constitutional symptoms, opportunistic diseases, and unfortunately death. So AIDS is that, again, that acquired immune deficiency syndrome. Sorry, I think I said adult earlier, but it's acquired. And it develops from HIV. So when that CD4 count is less than 200, but you can also be diagnosed if your CD4 count is above 200, but you have an opportunistic infection. And these infections include things like lung infections, skin cancers, fungal infections like thrush or yeast infections. And although a few people may die a few months after infection, most live very many years now, and that is primarily because we do have effective treatments. And in particular, antiretroviral therapy or antiretroviral medications are our first line of defense here. And there are a whole bunch of different classes, and each attacks the HIV virus in a different way. So some of them block the HIV RNA from being used to build HIV DNA. So then it can't get into your nucleus and your DNA, because once the HIV virus injects its DNA into yours, every time your cell replicates, it's basically working against itself. It's also replicating the virus. There are also antiretrovirals that just prevent the HIV virus from entering the cell. They sort of make the cell wall impermeable to the virus. And there are some that just prevent it from inserting its genetic code into humans. So maybe that HIV DNA would be made, but then you wouldn't get that in there. So why do we have so many different types? Well, initially it was just to try to see what worked out best. But one of the problems that we run into is drug resistance. So as the virus multiplies, it mutates, and then the same medication that might have been working will no longer work. And so usually people, and why I included this image, is people are usually taking a cocktail of antiretrovirals to try to combat this, prevent this from happening. So there's no known cure for AIDS at this point in time, or HIV, but these medications can help you get to your viral load being undetectable. And if you're good about your medication and checkups with your doctor, this can be very sustainable. The example I like to use is Magic Johnson. So he was a basketball player, he now does commentating. He is HIV positive. And when that first came out, when he was still playing, that was a big deal because people thought it was a death sentence, right? But I mean, that was 20 plus years ago now. And he's obviously very healthy. Granted, he has the money to access the best medical care. We want to fully acknowledge that. But probably folks like him helped to make the assessments we needed to figure out how to make these medications accessible to other folks. So, but as you can imagine, there are a lot of psychological issues related to HIV and AIDS. Some just sort of related to coping with the illness itself, and others related to how the illness affects your brain. So a big one is adjustment to diagnosis. So sometimes people just need help adjusting to the fact that they have this diagnosis. This can be something that feels like a death sentence, even though it doesn't have to be. This is also a very stigmatized disease, right? So this is often still thought of as like a gay man's disease, even though we know anyone can get it, unfortunately. And at least 10 years ago, the fastest growing group of people in the US who were getting it were African-American women, who not all, but unfortunately a lot of them were married and their husbands were going out on the DL, which if you guys don't know that terminology, it's men who sleep with men, but often don't say they're gay. And they would contract it that way. And you're not going to come home to your partner and be like, let's start using condoms because they're going to be suspicious. And unfortunately, they would transmit it to their wives that way. There's so much stigma related to this diagnosis. that the clinic I worked at while I was on internship in Augusta, Georgia, did not refer to themselves as the HIV/AIDS clinic. They just called themselves Medicine Forward. Because in the Deep South, if you were seen coming out of an HIV clinic, you were immediately stigmatized. Everyone spread the word, right? And you were sort of a leper. So part of your job as a psychologist, when you work with folks who have this diagnosis, is helping them decide who they want to tell, who in their life will be supportive, and also who they need to tell, right? Who have been their sexual partners, who might be at risk as well. Treatment adherence is a big thing. Again, this is now a lifelong, you're taking this cocktail of medications every day. That's exhausting for some people, right? So a big part of what health psychologists do in general, honestly, for any disorder, but also particularly for disorders like this, diseases like this, is to help motivate people to actually be compliant with treatment, take their medications. So helping them adjust to taking the medications, getting them to do it consistently over time, helping them problem solve around the issue. So sometimes it is things that seem kind of like almost simple in retrospect, but really help. Like, let's get you a pill organizer. And you set them up for the week, and then you don't have to worry like, oh, I forgot one, right? They're all right there. Set an alarm on your phone. I don't know about y'all, but like I do this every day for the medications I take, right? It's just like, if I fall asleep, it wakes me up and then I take them, you know, things along those lines. And then again, as I mentioned, dealing with fatigue of treatment, because especially initially, you need to go to the doctor a lot as these medications get calibrated. And then, you know, you need to have regular care over your lifetime and sort of helping people adjust to the idea that you're going to be doing this for the rest of your life. But by doing this, that means the rest of your life is a lot longer. Depression. So some folks will be very depressed because of this diagnosis. Again, because of the misconceptions out there, a lot of people feel like this is a death sentence. They feel like they're facing death. They'll also be depressed because of the rejection by others of due to their diagnosis, or betrayal in the way they contracted it. So again, if you got it because your partner was out being unfaithful, whether it's a man, a woman, DL, heterosexual relationship, what have you, that's a thing you got to work through, right? And again, sometimes that is much more stigmatizing than others. So one of the folks I saw, well, a couple I saw when I was working in this clinic was a pastor and his wife. And the pastor is the one who initially contracted it. And so now they've got to deal with the fact that like he's probably going to lose his job in this very conservative town, right? Because his congregation is going to shun him. Some HIV meds actually have side effects, unfortunately, that can cause or worsen symptoms of depression. So it's obviously a lot to kind of like balance, right? Let's find meds that work for you, but also hopefully like help you to feel like you want to enjoy the fact that you get to be alive. And people who have additional diagnoses, so especially like the additional STDs like Hep B or Hep C, are more likely to be depressed. Again, it's more complicated treatment, right? It's just a lot more to deal with. Substance abuse can be both a cause and a consequence of HIV/AIDS. So sometimes the cause of infection is needle sharing by intravenous drug users. And sometimes once people get the diagnosis, they feel depressed, they feel anxious, and so they try to self-medicate. I had a very sweet, actually, guy was probably about y'all's age. I think he was in his early 20s, and he was just smoking a lot of pot to try to deal, which like, on the one hand I get, but on the other hand he was smoking it to the point that it was interfering with his life, right? Like he couldn't work and things like that. So this is a result of trying to self-medicate to deal with depression or just to adjust to the diagnosis. The problem is if you're abusing alcohol, you're abusing drugs, right? This can actually lead to lack of treatment adherence, because if you're blackout drunk, you're not going to remember to take your medications, right? And unfortunately, some substances can actually interact poorly with the antiretrovirals, so they can make them less effective. People who smoke cigarettes are more likely to suffer complications from HIV meds than those who don't. And smoking also increases the risk of long-term side effects like osteoporosis. So again, some of what we did was working with people on like smoking cessation and things like that. So, and I actually realized I didn't even explain to you how I worked with these folks. So I would go into Medicine 4 and there was like a doctors and nurses room where they would consult about different patients. And I would sit there, and then one of the doctors would be like, hey, we have a newly diagnosed person. Can you please go in and talk to them? Or, hey, this person came in and they're more depressed than usual. They probably need someone to talk to them. And there were, as with any doctors or really anyone in any profession, right? There were people who understood better what we could and couldn't do. So like, I always had a really good experience with the doctors who worked on my shift. But I'm thinking of one of my friends who, there was someone who came in and they had sugar gliders for pets, the little flying squirrels. And they were like, can we give this to them? We don't want to infect them. And the doctor was like, this old guy just looked at me, he was like, psychology. My friend was like, I can't answer that. So sometimes, people didn't quite understand our role. But most of the time it was really great. And integrated care, like that is becoming more and more the trend in health psychology. Social support is also very important for folks with HIV and AIDS. So you try to get them to tell folks, but then that can also lead to rejection or a lack of social support and feeling isolated. So then you have to help them try to, again, figure out who can they tell, who will be supportive. And one thing that makes this extra awkward is that non-disclosure of HIV status with a sexual partner is a crime in some states. And according to the Code of Virginia, it is a crime for someone who is HIV positive to intentionally transmit the infection to someone else via sexual intercourse, oral sex, or anal sex. In doing so, the transmitter can be charged with infected sexual battery, which is a Class 6 felony, and I believe also puts you on the sex offender registry. It's also a crime for someone who's HIV positive, sexual intercourse, oral sex, or anal sex with a partner without informing the person about the infection. The transmitter can be charged with, again, this one was a lesser, it would be a Class 1 misdemeanor, but still, that's a challenge. Another thing that a lot of people unfortunately have to deal with is trauma. So sometimes people can be infected via a trauma. If you're sexually assaulted, right? Or through incest, sexual abuse. And so when people have trauma, little things can be that much more difficult to deal with. And so that can make it even more difficult to help them with treatment adherence and things along those lines. And so they might suffer symptoms of PTSD, and that causes them to further isolate a lot of the times. And then one of the ways that the virus actually affects the brain is dementia. So you can get HIV or AIDS associated dementia. Essentially what happens is as the virus progresses and it really attacks your immune system, you start to lose brain functioning. And so you can have word finding difficulty, forgetfulness, psychomotor slowing, where it's just harder and slower to do things, diminished skills in writing, like physically writing, and diminished visual motor skills, things like that make it difficult and maybe even dangerous if you're trying to do things like drive a car. You eventually lose your coordination. You lose your executive dysfunction, which is what allows you to sequence events in your life. So executive function is what tells you, I should put my socks on before my shoes, right? And I have to do X, Y, Z in order to get to class. They'll have an unsteady gait. And then it'll affect them in other ways psychologically, where they'll experience apathy, irritability, and mania or psychosis. Again, I had a client who told me he was seeing someone in the room who wasn't there. He's like, I know they're not there, but I see them. I was like, okay, good, I'm good to know where it is about for that. So what do we do to actually help these people? So a lot of times our interventions for people in a health psych setting are much shorter than the psychotherapy we talked about in the last chapter. So in psychotherapy, you typically have the luxury of having at least 6 sessions, if not, 20. And a lot of times when you're doing this type of work with in a health psych setting, you're going to see that person maybe once. And so you're going to be much more proactive. So how does psychology get involved? The biggest thing is that consultation, where you will be in primary care clinics and go in right away to talk to the person. And you can refer them for psychotherapy, but it needs to be cost effective and it needs to be accessible. Unfortunately, like a lot of things in our society, viruses like this tend to hit those of lower socioeconomic status harder. And so then if you expect them to come to therapy and they don't have insurance and you're going to say, oh, it's $300 an hour, they're just not going to come. So for example, the clinic I worked in, the psychologist in charge had actually gotten a grant so that they could provide very low cost therapy to people. Actually, I think it was free now that I think about it, which is even better. And then techniques that we use. Behavioral activation is getting people to fake it till they make it, go out and act as if you're not depressed, go out and do things you enjoy. A lot of it is just problem solving. We work with the person. How can we make taking your medication easier? Who in your life will be supportive if we go to them? Assertiveness training might be really important in terms of teaching them to advocate for themselves when they're at a doctor's office who's not their HIV doctor. Unfortunately, even within the medical field, there are misconceptions about this disease. And so some people won't treat people, will be very hesitant to treat people. For example, one of the most important things that our supervisor taught us is it's so important to engage in human touch with them. So shake their hand when they come in, maybe put a gentle hand on their shoulder, because so many people in their life won't touch them because they have this misconception that if they do, they're going to catch it, even though it comes from fluid exchange. Sleep hygiene. So teaching them techniques to help them relax at night so that they can sleep. Similarly, if they're feeling very anxious, teaching them methods like relaxation or meditation. And then pain management. So this is something that because of the early stages of the virus, you're just sort of like, what's happening, blah, blah, blah. You might not think to ask your doctor about like pain meds, but some of this can be really painful. And so talking to them, not only again, I hear about being assertive for there, but also there are psychological techniques you can use for pain management. Alrighty, so the next thing we're going to talk about is obesity and bariatric surgery. So while I was a 4th-year graduate student for my placement, which was 20 hours a week in a community setting, I worked at a hospital and I largely did pre-surgical evaluations for bariatric surgery. I think I did 141 over the course of the year. And so one thing I'm going to step back and say, because I think I have a very different view now than even when I, again, created these slides like 10 years ago. Obesity is sort of a strange construct because the body mass index of BMI we use to diagnose obesity is a flawed metric. So it's just a ratio of weight to height. It doesn't include things like muscle. So a lot of athletes will end up being labeled as overweight or obese just because muscle weighs more than fat. Also, with the exception of very extreme obesity, there isn't the science that people think to tie diseases to being overweight. And in fact, there's research that shows that being overweight, you actually have a longer lifespan than someone who's underweight, because there are health complications with that as well. BMI itself is also really problematic. It was developed by a mathematician in the 1700s, 1800s, somewhere in there. And he meant it to be used only to measure it on a group level. And he was a eugenicist. So he was a person who believed we should be creating like a pure race, and those who were obese, we should not let them breed, right? So the fact that we now use this somewhat arbitrary measure to make these diagnostic calls is really problematic. The last thing I'll say about how BMI is problematic is in the 1990s, the CDC, or maybe it was the NIH, one of the two, decided that the BMI cutoffs were too hard to remember. I think the cutoff for being overweight used to be 27 or 28 point something. And so they just lowered it to 25. And so overnight, a whole bunch of people who were quote unquote normal weight suddenly became overweight, right? And over nothing other than someone deciding that number was easier to remember. So fully disclosing this is problematic, but also fully recognizing this is a thing people do. And so we know that overeating is an issue. And again, it really is when you get into this really high, what's sometimes called morbid obesity level, that we see the increases that are potentially really problematic in things like blood pressure, musculoskeletal pain, heart disease, and diabetes. Diabetes is a really interesting one. It actually, and I mean, heart disease seems similar as well, seem to actually be more related to gaining and losing weight than just gaining weight. So they've done studies where they compare people who are dieted, like gained, loss, what's sometimes called yo-yo dieting over their lives, and compared them to people who are overweight or obese who've never done that. And the people who are overweight who've never yo-yo dieted don't have the health problems, don't have diabetes. So it may be that our attempts to lose weight are actually causing some of these issues, because that puts a lot of strain on the body. Anecdotally, I've read that Tom Hanks, the actor, developed type 2 diabetes, gaining and losing weight for roles. So certainly people argue that this is something we should treat. Obesity, as defined by this flawed metric of BMI, is fairly common. 31% of women, 35% of men. And again, 2/3 of Americans would be considered overweight by this arbitrary cutoff of 25. But we're including a lot of people who are just muscular, right? And research suggests that some of these numbers are inaccurate. That being said, there are people who do have a lot of health complications at very high weights. So what studies have looked at are things like nutrition and health. So in terms of what's associated with the increased risk for heart disease is heavy consumptions of foods that raise cholesterol, too little fiber and high intake of red meats. And this is sort of like hilarious to me because again, I made these slides like 10 years ago and now like high intake of red meats, like that's keto, right? It's supposed to be healthy. So, you know, things change. And the basis for poor nutrition a lot of times is ignorance. People just aren't educated about it, or they might get like one day in health class, right? We don't really know what's good for us. And honestly, different things work for different people's bodies, right? Depending on lactose intolerance, gluten intolerance, all that stuff. And sometimes it's poor motivation that it takes a lot of effort to change your diet. And again, one thing that is not on this slide that we really need to acknowledge is sometimes it's access, right? And in fact, that one is so important, I'm going to add up a little bullet here. So many of the folks who live in inner cities, who are often the folks who are of lower socioeconomic status, live in what are called food deserts. And so these are areas where you cannot walk to a grocery store. Like, and a lot of these folks might not have access to cars, right? So then you either have to take public transit to go get your groceries and then haul all your bags back, or you're going to like a 7-Eleven to buy stuff. And I don't know if y'all have ever seen the quality of produce at 7-Eleven, but it's sketchy, right? And so I think there's been a lot of glossing over of the fact and blaming people, particularly poor people, particularly people of color, that, oh, you're not eating adequate nutrition, when like they just simply can't get it, right? And like eating organic vegetables is very expensive, and people be like, grow your own food. And I don't know about y'all, but like I had tomato plants this year, and I think we probably got like 20 tomatoes from June until now, right? Like I could not subsist on that, right? And so what are nutritional goals? We want a regular pattern of eating, and we want a balanced variety of foods. So we want to avoid excessive consumption of things that have high saturated fats, high cholesterol, refined grain carbs, sugar, and salt. That being said, you need to consume all those things. If you don't consume fats, if you don't consume salt, it's problematic. So I can speak from personal experience. During the pandemic, I was diagnosed with hypertension or high blood pressure. I think partially because of the stress of the pandemic, and also because, like many of us, I was like sitting on my couch eating chips. Fully acknowledge that, right? And I worked with a nutritionist to try to figure out what I needed to do to change my diet. And she was like, no, you need to make sure you get salt every day. So a lot of people be like, no salt diet. Like, no, your body needs that. Same thing, when I was pregnant, I was diagnosed with gestational diabetes. And whenever I tell people that, they're like, oh, you just didn't eat carbs, right? And then no, it's actually like this really complex metric where you need to make sure you eat X amount of carbs, X amount of protein, X amount of veggies at every meal. And doing that, I actually controlled my diabetes with just diet and exercise, never had to take medication while I was pregnant. And then very unfortunately, as soon as I gave birth, it went away, which is pretty common. And then you want to eat more whole grain carbs, natural sugars, foods with fiber, polyunsaturated fats. And again, a really important thing from coming from more of my eating disorder background is you want to make sure you're not denying yourself stuff you like to eat. Because if you say, I'm never going to eat any sugar, and then you're having a bad day and there's that unopened box of cookies, you might eat all of them, right? Whereas if you have 1 or 2 a day, it's much less problematic for your body. You want to have a regular pattern of eating. So whether we work with people with eating disorders or people who were experiencing health issues because of obesity, we would use the same tactic. And in fact, every nutritionist I've worked with has also used the same tactic. Regular pattern of eating 3 meals, 2 to 3 snacks a day. You basically never want to go more than 3-ish hours without eating. That keeps your metabolism rolling. If you are experiencing something like diabetes, it helps to maintain your insulin levels. It also just stops you from ever getting like too hungry, right? And overeating as a result of that. And then never letting yourself get too hungry. And then the hardest part of this is figuring out when you're hungry and when you're actually full. This is like really, really difficult to learn. I tried in grad school when I started teaching this to clients. And it's difficult because we're so used to just eating quickly in between things and then we go, right? But when you try to tap into those, then you start to recognize more what your body needs and wants. Exercise, as I think everybody in here knows, is also beneficial. It helps with cardiovascular fitness. In theory, it can help you avoid obesity, but there are marathon runners who would be considered obese, and they can run faster than me, right? So like some of this is questionable. Also decreases risks of cancers and protects from stress, and has a positive effect on mental health. Sidebar with that, as long as exercise is not a problematic part of your mental health, right? So if you have an eating disorder and you're using exercise in an obsessive way, that's not going to help, right? And it can also help with desirable personality traits. And this doesn't have to be marathon running or kickboxing. It's like, find something that works for you that you enjoy doing, so it won't feel like a chore, right? And for some people, that might just be walking. For some people, it might be doing spin classes or weights, things along those lines. So yeah, here we go. Choose an activity you enjoy, increase your participation gradually, because if you dive in too fast, you can injure yourself, right? And then you're not going to want to work out. Exercise regularly without overdoing it, and then reinforce yourself for exercising, you know? Give yourself a pat on the back, or if you have a chance, sit down and watch, you know, a half-hour show on Netflix, something like that afterwards. All right, so bariatric surgery is this extreme measure. And so in order to even be considered for this surgery, you have to have a BMI of over 40 or a BMI of over 35 with medical complications, typically diabetes, high blood pressure, things along those lines. And there are really 3 types now. The other one is gastric sleeve, but that's just sort of a different version of gastric bypass. I'll talk about that briefly when we get there. But Roux-en-Y gastric bypass, and then lap band is one of the brand names, but there are different types of gastric banding. So the outcome initially, I should say, is loss of up to 75% of your excess body weight with the Roux-en-Y bypass, and a loss of up to 50% of your excess body weight with the lap band. Long-term research, however, is showing that people often, if you go past 2-year follow-up, which is what the initial studies did, people often are regaining the weight. So that's important to know too, before you go and totally alter your body, right? So this is the gastric bypass, and hopefully this doesn't gross people out too much early in the morning. I'll use the mouse so that people here can see. So what they do is they create a smaller stomach. And the stomach they create is about the size of your fist. And then they also remove part of the small intestine. So typically this would be connected to that. And then when they do this sort of rerouting, they take out part of the small intestine. Doing so purposely creates malnutrition. And that's one of the mechanisms by which people lose weight here. So the rest of the stomach stays intact, but is bypassed, with the exception of the duodenum, which is attached here so that the enzymes you need to digest food still come in. So this is done laparoscopically, which means rather than doing like a giant incision, they have 6 little holes, and they have instruments that go in there, including a camera, and they do everything that way. And then you only have 6 little scars instead of a giant one. It's also a lot safer in terms of preventing infections, side effects, things like that. The banding is you kind of do the same thing, but it's a lot less invasive. So you go in again laparoscopically, and you put this band around the top of the stomach. So you're still creating the smaller stomach, like the size of the fist, but you're not cutting away the stomach. You're not removing any of the intestines. And then there's this line that runs to a port under your skin, and the doctor can actually tighten or loosen your lap band by injecting or removing saline. So this is adjustable. This is much less invasive. The diet is less restrictive, but you do have to make more life changes. You need to exercise more. So for some people, this is not as feasible if, say, you know, like their morbid obesity has caused joint issues. One thing I didn't mention with the gastric bypass is the diet is very restrictive. So you cannot have carbonated drinks, you cannot have anything too greasy, too heavy. With both of these, you can only eat a little tiny bit at a time. With gastric bypass, if you eat the wrong thing, you can experience a symptom called dumping, where it's basically stuff just runs through you. Like Al Roker, the weatherman from the Today Show, he had this surgery years ago and talked about an incident where he was at like a state dinner at the White House and had to like run to the bathroom in the middle of it because he was experiencing some dumping. Another problem I should say with both of these is that the stomach is very elastic. So even if you push this just a little, it can stretch back out. And that's like the proposed mechanism by which a lot of people regain weight. So what does psychology have to do with this particular surgery? Well, this is a very significant surgery. Even though they do it laparoscopically, you're still messing with your gut, right? Very vital parts of your body. So just adjustment to it, and particularly the lifestyle changes, can be really difficult. And you need to make sure you have all the resources you need to succeed post-surgery. So when we did the pre-surgical evals, in addition to just asking about their psychological symptoms, we would ask things like, how will you cope if you're feeling overwhelmed? Or how do you currently cope if you're feeling overwhelmed? And a lot of them would say, well, I eat. And I would say, well, what would you do if you couldn't eat? And some people would rattle off a few things and be fine. Some of them would be like deer in headlights. Like, what do you mean? Right? And so we would do therapy with those people, not necessarily for any like deep psychological issue, but just to sort of help them come up with other behavioral things they could do. And in fact, we had a really great group that people both pre and post surgery could join, and they helped each other with ideas like this. So things like Sudoku or knitting, where you're keeping your hands busy, going for a walk, talking to a friend. Eating and emotions are very linked and can be difficult to separate post-surgery, as I just outlined. So there are some positive things post-surgery. So people often have improved mood and improved self-esteem and improved motivation to maintain those behavioral changes as they do see success. However, there can be some challenging things. You can only eat so much, and you go out to dinner with people, right? And they're eating these giant meals, and you're taking at least half of yours home, right? It's a sense of deprivation. The need for developing those alternative coping skills. Some people will already have or develop body image issues. One of the things that happens when you lose weight really, really rapidly is you can actually develop like skin folds, because it was like your weight went up faster than your skin could adjust. And so some people find that very problematic and will go to get it removed, but that's not considered medically necessary. So it's a cosmetic procedure and you have to pay out of pocket. So that can be really pricey. They'll have a fear of weight regain or kind of feel a setback when they're not meeting those weight loss goals. Alrighty, so we will stop there for today. We'll talk about the research findings next week. And yeah, it was good to see you. Have a happy Thanksgiving to folks here and folks on Zoom.